Good afternoon, everyone. Thank you for joining us this afternoon for our virtual introduction to the Gray Center for Mobility and Activity. I'm Roy Butler. I'm the President and CEO of St. Joseph's Healthcare London, and I'm joined today by Jeff Weiler, the coordinator for the Gray Center, who's going to act as kind of the MC throughout the next hour. A couple of just housekeeping items. Reminder to please stay on mute, put your phones on mute or computers on mute during the talk. If you do have questions, you can certainly enter them in the chat, and Kelsey Brake has provided that direction in the chat, or send them directly to the email link to Jeff Weiler as well. We've got a great lineup of mobility experts today, sharing their exciting work. But before we begin those presentations, I just wanted to spend a couple of minutes giving a bit of a background on how we got to today and to the Gray Center for Mobility and Activity. It was actually 5 years ago that Michelle Campbell and her amazing foundation team put out a call for proposals. And at that time, Dr. Tim Doherty, Chair Chief of Phys Med and Rehab, researcher, thought leader, physician in physical medicine and rehab, and Dr. Dalton Wolf, scientist at Parkwood Institute and at Lawson, who I see is on the call today as well, responded. And they started to draw a picture of a vision for a mobility and activity center. They identified a need, a growing need for individuals who are suffering from mobility impairment, and saw Parkwood in particular as a regional and provincial leader in rehab, positioned to take an accelerated step on care, teaching, and research and innovation and creativity to solve mobility and activity problems and provide more creative programs to individuals. Our senior team grabbed onto that idea and supported that vision, and then started to form partnerships, particularly with between our foundation, Lawson, our organization, and Western, and collaborations with Schulich and the Faculty of Health Sciences in particular. And then entered longtime donors and philanthropic investors to our organization, Bill and Lynn Gray. For those of you who don't know, Bill's kind of a second generation owner of Gray Ridge Egg Farms, one of the larger kind of farm to table egg producers in Ontario or in Canada. And I've just been absolutely dedicated supporters throughout the lifetime of St. Joseph's. And they got behind this idea and donated $7.5 million to make the vision a reality. Western then stepped forward, matched $2.5 million to create a $5 million endowed research chair. And that first chair who you're going to hear from today, virtually, because she's in Australia, Dr. Siobhan Chabran, but she will be landing in London, we're hoping in the February timeframe. So there's been, even through the pandemic, significant work to move the Mobility and Activity Center forward. Just a few shout outs, and I'm sure I'll miss people, but certainly Michelle Campbell and the foundation team, Kelsey Brake from communications, I mentioned Jeff Weiler, Joan Kemp-Hubert, who is our patient partner, Dr. Bob Teasel, who's provided great leadership in this space, Stephanie Cornell, Cheryl Forchuk, Dr. Jane Gartland, the Dean of Faculty of Health Sciences, Andrea Lee, and Vanessa Cullen, and others. So enough said for me. I actually want to kind of turn it over and have the most important story told, which is what's the impact for those we serve, and what can be the potential impact and as we move forward. So we're going to hear a story first from Paul Garrett.
My name is Paul Garrett. I'm 62 years old, and I'm from London, Ontario. I was getting up to go to work like a normal day, and I was downstairs making coffee, and all I felt was a tingling in my toes. And then it started going up my legs, and I thought, oh geez, I just, it's my pins and needles, odd time, pins and needles. And it kept getting worse and worse. And it traveled up to my rear end and across, and then down the other side. I made it upstairs to the bedroom with Brenda, who in turn called an ambulance because I said to her, I can't walk. And it was 30 minutes from the time it started to when I was paralyzed from the waist down. They thought it was a spinal stroke at first. And then MRIs came through and showed lesions on my spine, transverse myelitis. and I got the sudden onset of it, and it's basically the myelin on the base of the spinal cord gets a lesion, and the spinal nerves are no longer protected, and so they stop sending signals, as they did to me, to my lower body. There was sadness at times because all of a sudden your life has stopped, my business was stopped, everything burdened on my caregiver, my wife Brenda, but I knew that that time what I had to do was do my best to get better. I remember dealing with some of the equipment that I worked on, and there were FES machines that are functional electronic stimulation. It sounds great, but basically they electrify me. But they make my muscles feel again. The first time I used that, when I got off, I could actually feel my legs again, short term, but for the first time. So that was amazing. And I was standing for the first time. I was 6 foot tall again, because I've been looking at the world from down to up, you know. If I get the opportunity to meet the Greys, I don't think a handshake will do it. I think we're going to have genuine family hugs, because I want to thank them so much and they're going to thank me for being a part of helping others as well by being here. So I'm going to thank them and just for everyone in our community. And I don't have the words to say it. I mean, I'm getting chills. To understand a need and to go after a way to fulfill it, the best their ability, and giving people free hand to do that, the professionals, to say, okay, how do you map this out? Let's give a big hug there. That's family time, you know.
Fantastic job, Paul, on the video, and thank you for sharing your story. And Paul and Brenda, thanks for joining us here today. I mean, I think it's just one example of the many that the impact the Gray Center can have on those we provide care for. So, without further ado, I'll turn it over to Jeff to introduce our first speaker.
Great, thanks, Roy, and thanks everyone for joining us today. We've got 5 speakers that are going to share little mini snippets of their research program. Over the next several months, we're going to have these researchers come back and then give each a full 1-hour overview of the work that they've done in the area of mobility and activity and how the Gray Center is involved in that work. With 5 speakers, we're going to be quite tight on time, but we still want to have an opportunity for questions and answers. So after each speaker, we're going to ask that you hold off on questions, and we'll try to address all the questions at the end. If we run out of time on that, I will provide all the speakers' email addresses as well as my own, and you can send us your questions directly, and we'll get back to you as soon as possible. Our first speaker is the incoming William and Lynn Gray Chair of Mobility and Activity at Parkwood Institute. As Roy said, this is Dr. Siobhan Chabran. She is currently in Australia, and it's 3 in the morning right there, so she couldn't give her presentation live, but she has sent us her presentation, and I'm going to play that for you right now.
Thanks very much. I'm sorry that I wasn't able to join you for the launch of the Gray Centre this week, but I am very much looking forward to joining you all in 2022. I was asked to give a very brief presentation about my research, which focuses on the idea of harnessing the brain to reduce pain and improve mobility and activity. I'm a physical therapist. I have a PhD in neuroscience, and my research is really focused on the idea of assessing and inducing neuroplasticity, so this idea of beneficial brain rewiring, across a number of different conditions. My team has explored work in healthy individuals, looking at maintaining function into old age. We use human experimental pain models, so we induce pain in otherwise healthy humans and look at how the brain undergoes plasticity in response to pain. We've looked at plasticity in movement disorders like focal dystonia and in neurological conditions like Parkinson's disease, as well as in chronic pain disorders like low back pain, neck pain, and knee osteoarthritis. So my program of research really doesn't focus on any one particular condition or disorder. It has very broad applicability, looking at this idea of how we might harness neuroplasticity to improve outcomes for a range of different people in our community. My overarching research vision is to eliminate barriers to mobility and activity in health and disease. We know that mobility and activity are good for our health. We know that they're good when we're fundamentally healthy, and we know that they're good in helping us to recover from musculoskeletal or neurological injuries or diseases. But there are a number of barriers that sometimes make it difficult for people to be mobile or active and can impede rehabilitation across a variety of different conditions. My research program is quite large and it's quite broad. And in the interest of time today, I've just chosen two key research themes to talk to you about. One is harnessing neuroplasticity in health and disease, and the other is eliminating pain to enhance the outcomes of rehabilitation. Theme one, learning to move again. The rehabilitation of movement is the mainstay of therapy for musculoskeletal and neurological conditions. But there are some barriers to this. Learning to move or relearning a movement skill is inherently very difficult and time-consuming. You know, if you pick up a tennis racket as an adult and start trying to hit balls over the net, that if you've got no prior experience, it takes many, many hours of intensive, repetitive practice to get you up to a level where you're decent. And this is the same for people who are relearning, for example, to do up buttons after a stroke, or relearning how to walk again after a musculoskeletal injury. And this huge amount of intense practice creates complexities around adhering to an exercise or a movement therapy plan, and in terms of people's motivation to keep going. This is particularly so if the right support structures or access to health care resources aren't in place to support these kinds of movement therapies. So for example, after somebody is discharged from inpatient rehabilitation or community rehabilitation, they might struggle more and more to adhere to their exercise therapy as time goes on. So one of the ways my team has been looking to solve this problem is by using non-invasive brain stimulation to prime the brain, so to get the brain ready to undergo beneficial plasticity in response to exercise therapy. And in doing so, we hope that we can produce larger and quicker gains in function than if we did exercise therapy alone when the brain wasn't primed, when the brain wasn't really ready to undergo the kind of plasticity we want to support new forms of movement. So here I'm showing you an example that my team did in knee osteoarthritis, where we combined 8 weeks of physical therapy consisting of exercise with non-invasive brain stimulation. And we found that in our group who had both brain stimulation and exercise, they had much greater gains in function over the 8-week time period than those who had exercise therapy alone. And you can see that here in this figure. Here, the dotted line is the minimum clinically important difference. And you can see that our combined brain stim and exercise group had very substantial gains in function. So this is an area of work that I plan to continue to pursue into the future across a number of different conditions. Priming the brain to enhance plasticity has relevance for chronic pain disorders. It also has relevance for neurological conditions. So there's a lot of scope to see whether this might be the kind of therapy we can use as an adjunct in the clinic in the future. Theme 2, pain, like love, is all-consuming. Pain is the single greatest cause of reduced mobility and activity throughout life. And if you've ever lived with severe pain or pain that is persistent, you know that it interferes with everything you do. It interferes with your ability to work, with your ability to enjoy your recreational activities, with your ability to move, and sometimes even with your ability to just think. Pain is a primary reason for seeking healthcare in musculoskeletal conditions. It's very common in neurological conditions, but it's both underreported and underdiagnosed because the focus often is on returning people to being able to move, to being mobile and being active. So there are a number of mobility and activity barriers associated with pain. One is that we don't have very good tools for reporting pain. This is particularly so in conditions like stroke, where people may also be having problems with speech and language. We know that pain reduces people's mobility and it can alter the way that they move, which in turn changes the loading of their joints and their muscles, and that in itself can then cause more pain. So people tend to get stuck in this vicious cycle: pain, less movement, pain, less movement, pain, less movement. And that can be very difficult to break, and it can impede rehabilitation. Unfortunately, we're not able at this time to predict who might develop persistent pain after neurological or musculoskeletal injury, and there are no effective treatments for persistent pain. So my team is looking to answer this question in a number of ways. One, looking at biomarker development, so the idea that we might be able to predict who develops persistent pain, and treatment development, specifically looking at treatments that target brain plasticity. Here I'm showing you an example of work down the biomarker validation end of our research program. And what we've shown is that people who experience acute pain show one of two patterns of cortical plasticity. They either have a decrease in excitability, so a depression of motor plasticity in the brain areas that control movement, or they have a facilitation, an increase in excitability. Those who show depression of motor plasticity have higher pain, they have greater disability, and they have slower recovery. And we theorize that this might be a valuable biomarker then for predicting who might develop persistent pain. And we have a lot of ongoing work in human pain models and in clinical pain populations to validate this as a marker. So in summary, my work seeks to eliminate barriers to mobility and activity by harnessing neuroplasticity and reducing pain. And it has the potential to improve outcomes not only for healthy individuals in terms of maintaining function over time, but also for those living with musculoskeletal and neurological conditions into the future. A big thank you to my team at the Centre for Pain Impact and to my funding sources, NIH and NHMRC. Thank you very much for listening. I look forward to joining you all soon.
That's great. So as we said, Siobhan will be joining hopefully around the beginning of February, and she will be, although a Faculty of Health Science professor, embedded within the Gray Center here at Parkwood, Maine. Similar to that, in that vein, we have another Faculty of Health Science professor who is already on site at Parkwood, Maine. That is Dr. Sue Peters. She'll be presenting next, and she'll be sharing her research program, which is at the forefront of mobility and neuroimaging. So Sue, take it away.
Hi, everyone. Thank you so much for having me. I'll be talking a bit about my research program on wireless neuroimaging during mobility to predict recovery after stroke. So I was treating a stroke patient during outpatient therapy, and I noticed that he had a bruise on his face and his knee. He told me he was out for a walk with his granddaughter, and the path up ahead became rough, and his granddaughter was able to adapt walking very easily, but he noticed that he had to slow down and stop talking to be able to adapt to the rough path. Despite slowing down and concentrating, his knee ended up buckling and he fell. So after a stroke, for a lot of individuals, about 70% fall within the first 6 months after their stroke. And even more than this, 1 out of 3 stroke survivors do not walk in their community for many various different reasons, whether it's confidence or whether they feel like they are unable to move about properly. So the question that I'm asking myself, knowing these things, is what is it that we're missing during rehabilitation? So there are very real consequences of stroke location on mobility, and this really depends on the region of the brain damaged. So if there's a stroke that involves the frontal lobe, we have effects on mobility, such as planning and attention. If a stroke is a little bit further back in the brain, in the parietal lobe, we have damage to sensory processing. And this impacts things like the feeling or the sensation coming from your foot, or not being able to tell where your limb is in space, otherwise known as proprioception. So the fact is that stroke damages the brain, and yet measures of how the brain works and how the brain recovers are not yet incorporated into mobility rehab. So what is it that we're leaving out? What is it that we're missing because of this? And I think that part of what we're missing is that we're not using neuroimaging measures really well in informing our mobility assessments and treatments after stroke. And I think that big gap is because there's a lack of research in this area. So I'd like to tell you a bit about the research I've completed that examines the brain and the muscle recovery after stroke. So in this particular study, I had individuals who were inpatients with severe stroke, so people that were unable to do much more than just standing beside their hospital bed. And I record their muscle activation over time and track their progress during inpatients. And at this very first time point here, this is where the very first assessment of their muscle activation occurred while they were admitted to Parkwood here. And at the last time we assessed them, so at the end of their inpatients, for most individuals, they were able to increase the amount of muscle activation that they had while they were standing and moving. But there were a few individuals where the muscle activation that they had actually dropped off or leveled off during their time in inpatients. So I want you to keep this in mind as I describe the next study. In this particular study, I recorded a brain measure called electroencephalography, and that looks at the electrical activity of the brain. And similarly, I had individuals come at the beginning of their therapy and come back into the lab at the very end of their therapy. And for the most part, individuals after a stroke took a long time to plan a movement. But after therapy, some individuals were able to plan a movement in the same amount of time as a healthy individual would plan a movement. But I want you to notice again, there's some individuals here that fall outside of that healthy adult duration or don't seem to really show a real improvement of recovery. For these particular individuals, I'm asking myself is whether the physiotherapy intensity was high enough. And so along that same line of questioning, I've looked at whether gait speed and age can be used to individualize mobility rehab. And so I took data from a mobility trial and looked at the number of steps that individuals received during inpatient therapy. And the yellow or orange line here at the bottom is the amount of steps per physical therapy session in typical care. When we asked therapists to try to increase the number of steps that individuals were completing during therapy, we found that even individuals that walked very slowly were able to almost double the amount of steps right at the beginning of their therapy, and were able to achieve at least 2,000 steps near the end. And if we look at the number of aerobic minutes, we see a similar message here, where in usual care, individuals were receiving about 8 minutes of aerobic therapy per physical therapy session. But if we asked therapists to try to increase the intensity, they were able to almost double the therapy in the beginning. And at the end of 4 weeks of therapy, individuals were almost getting 20 to 30 minutes of aerobic intensity. So building off of this, we know that higher aerobic intensity improves walking outcomes. But the interesting thing is that impacts this particular implementation is that many individuals have leg weakness that prevents walking practice at the level needed to generate that level of change. But based in the healthy adult literature, we know that bike-based aerobic exercise can facilitate brain changes or neuroplasticity, which Dr. Chabran talked about quite well in her presentation. So the question stemming from this is, can bike-based aerobic exercise improve walking outcomes for individuals after stroke? And are walking outcomes associated with brain changes? So this is a really exciting study that I'll be launching in the next few months here at Parkwood, is to look at the brain changes and whether they're associated with increased aerobic intensity. So I'll be doing brain assessments before therapy and then have individuals receive the amazing therapy that they receive here and see if we can combine that with some added extra aerobic therapy. And then again, measure their brain after. And so I do think that if we can measure neuroimaging in mobility tasks at multiple time points during stroke rehabilitation, and we combine that with tracking their mobility recovery over time, I think we'll be able to generate this map of mobility recovery trajectories that will really feed into my long-term research vision that can build this map or this picture of what types of individuals and how their brain activation may change over time. And we can generate an algorithm using artificial intelligence that can allow us to design new interventions for those who need it the most. So I'd like to acknowledge for sure the study participants as well as my collaborators and my funding sources. Thank you.
That's great, Sue. Thanks very much. Really interesting work. If anybody has questions for Sue, I'm just going to ask you again to hold them till the end of the presentations. Our next presenter is Dr. Swati Mehta. And as we all know, the last 18, 24 months have been particularly challenging with COVID-19. Swati is now going to speak about providing virtual interventions during this pandemic. Swati?
Thanks, Jeff. I'm just gonna share my slides. Sorry. Can everyone see them? Yeah, perfect. Thanks, guys. Thanks for having me here today, guys. I'm just going to speak a little bit about an online program that we delivered during the COVID pandemic for those with spinal cord injury to help improve their activity engagement. This is a very small feasibility study, so I'm just going to give you a very brief overview of the program, and I'm happy to answer questions later on. So as many of you may know, engaging in physical activity has several benefits. And amongst those with spinal cord injury, these benefits range from enhanced health, from prevention of secondary health complications to improved overall well-being. And regular engagement in physical activity has been shown to be linked to decreased healthcare costs and fewer hospitalizations. And so currently, the spinal cord injury physical activity guidelines recommend that we should have at least a minimum of 20 minutes of aerobic exercise and strength training twice a week. However, only 12% of the population actually meet the recommended guidelines. And so even under optimal conditions, you can see that persons with spinal cord injury face lots of barriers to access to some of these physical activity programs, especially things like, physical access or access to safe and monitored programs that can really limit their engagement in physical activity. And so during the pandemic, the individuals experienced even more additional barriers, which resulted in several concerns such as reduced social connectedness, feelings of depression and anxiety, and overall well-being. So one solution may be to have virtual programming, not just during the pandemic, but also to improve access to these evidence-based services in the long term. There are several community-based online physical activity programs. However, there's a lack of evidence in the acceptability and feasibility of these when we're looking at group-based programs amongst those with spinal cord injury. And this is really important because research has really showed that the key component to long-term engagement in physical activity is the development of social networks and programs that foster group-based strategies. And so what we wanted to do was we wanted to evaluate the feasibility and limited efficacy of an online program in improving psychosocial well-being amongst those with spinal cord injury. So what did we end up doing? So what we did was we developed a seated boxing style program through a collaborative process, and then we conducted a pre-post feasibility study. We recruited patients from Parkwood Outpatient Clinic and the Fitness Center, and we included those who had sustained a spinal cord injury, were living in the community, and had at least one upper limb function, permitting them to have an arm movement against gravity. And each of the participants received an individualized pre-session assessment in order to evaluate their abilities and also make modifications to the steps based on their abilities and their needs. We also conducted risk assessments and safety planning just to make sure that patients felt that they were comfortable with the steps, and also any psychoeducation about the program that needed to be conducted. The online fitness program consisted of 60 minutes sessions delivered twice a week over 6 weeks. And the session was broken down into a 10-minute warm-up, a 25-minute aerobic exercise, and strength training exercise, and then 10 minutes for cool down. We also tried to incorporate 15 minutes of peer social interaction, which was moderated by the fitness instructor. And so this is a very brief, just an idea of a video that our fitness instructor, Randy, has conducted. And it just shows you some of the moves in the program. And based on everyone's abilities, we encourage them to add equipment such as dumbbells or stretch bands through the process. So just to give you a bit of the results, as you can see, we had a wide range of individuals participate in the program, age range from 38 to 70 years. Many participants had incomplete injury and paraplegia. Most of the participants were women. In terms of satisfaction, all participants really reported high levels of satisfaction with the program in general. They reported that they could continue to participate in the program and really recommend it to others. They felt that the program had positive improvements on their physical and psychological health. And when we looked to evaluate how this group-based approach helped to improve the physical activity program, we found that the participants really felt that the social experiences from the physical activity group were really important to them. Participants felt that they were encouraged with each other in order to get the most out of the program. When we look at just the preliminary efficacy findings, we find that we had large effect sizes from baseline to post-intervention on depression and anxiety outcomes, with anxiety outcomes being maintained over a 3-month follow-up. We also found that there was significant improvement in participants' satisfaction with their social roles and activities. This was at post-intervention, and they continue to improve in these over the 3-month follow-up. And so just to give you an idea of some of the lessons we learned from this program, consistent with other studies, when we look at physical activity, we found that significant improvements were seen in depression and anxiety. But specific to our study, we also demonstrated that, having a virtual physical activity program that incorporates group-based social interactions that may help kind of develop a sense of social connectedness and a sense of community. And these social connectedness and interactions may also help to serve motivation to continue engagement in the long run. And then our study also paid particular attention to health concerns people may have. So the initial pre-session assessment allowed the team to provide education about red flags and raise any awareness of adverse events that may occur. Another lesson we learned was that the instructor was able to kind of personalize the exercises based on each of the participants' needs and perhaps abilities. And the spotter involved in the program was there to ensure that participants were following the steps appropriately and made sure that, no adverse events were occurring. Of course, our study was not without its limitations, as it was a feasibility study. It had a small sample size, so we would like to conduct a larger population sample and a stronger research design. Additionally, as the study was conducted during the pandemic, access to services and social interactions may have changed, and so this could have contributed to some of the results. The study also was led by a person with lived experience, which may have influenced the acceptability and the outcomes. So it's really important to evaluate this effect, because if we want to scale up the operations and perhaps deliver it to a larger population, it may not always be feasible to have a person with lived experience lead the sessions. But despite these limitations, I think the current study had important clinical implications for the development and delivery of virtual physical activity programming amongst those with mobility impairments. The program allowed us to increase availability of accessible and evidence-based services that minimize physical and environmental barriers to activity engagement. The online program has the ability to further personalize and meet the needs of a larger population. Concerns related to safety and perceived difficulty can be addressed through pre-session consultation and presence of spotters. For our next steps, we're currently working with a large team to expand the program. What we want to do is we want to embed behavioral strategies that promote self-efficacy and enhance long-term outcomes. We've also developed new sessions such as seated yoga and seated aerobics. And we want to include some more objective measures for activity engagement. So things like heart rate monitors and accelerometers to see how people are engaging in activities outside of what we're delivering. This new expanded program is being targeted to all those with mobility impairments, not just those with spinal cord injury. So we would include people with amputations, those with strokes, and geriatric populations. And the idea behind the program is that we're hoping to expand the virtual physical activity program to promote Parkwood and the Gray Center as a community hub where everyone with mobility impairments can access evidence-based services that improve mobility and activity engagement. And now I just want to take a moment to thank our team and our participants, and I've just left out my email in case anyone has any questions.
That's great, Swati. Thanks a lot. As I mentioned at the very top of these presentations, that we are going to be having longer form presentations in the months to come. Dr. Swati Mehta is going to be our first presenter. I'll give more information to that at the end of these talks, but hers will be an hour-long talk on January 25th, and we'll send out save the dates for that. Thanks a lot, Swati. Our next presenter is Dr. Manuel Montero Odasso. He is the director of the Gait and Brain Lab at Parkwood Institute, and he will be speaking on the linkage between cognitive function and mobility. Thanks, Manuel.
Thank you, Jeff. Thank you for the invitation to everyone. As Jeff said, I'm Manuel Montero Odasso. I'm a geriatrician and clinician scientist here at Western, professor in the Department of Medicine and Epidemiology and Biostatistics at Shoreditch, director of the Gait and Brain Lab, and privileged to hold other positions in the Canadian Geriatric Society and in the Canadian Consortium on Neurodegeneration and Aging. I would like to start with the acknowledgement, right? Because I will present to you achievements. They are not my achievement. All the achievement we have done in our program have been a real team effort from my lab members, several of them attending to this webinar today, national and international collaborations, and last but not least, all the agencies that provide peer review fundings for the last 15 years. When I think what makes a person look old, two things come to my mind. Slowing mobility and gait, so when we age, our mobility and walking is not the same, but also mental slowing and a slowing cognition. Interestingly, for those clinicians here in this talk, we do know that not only those problems are independently associated with decline, but also they concur. So what is our mission? Our mission in the Gait and Brain Lab is to integrate mobility and cognition as a new line to better understand and treat the epidemic of insidious disability in older people. Because as I said before, those impairments not only are very prevalent, but generally they concur and generate more disability. All this started in 2008. When I moved from McGill in 2006, we were very fortunate to get some pilot grant from CHR. And by 2008, CHR invited us to lead a mobility workshop. At that moment, Ann Matthews was the director of the Institute of Aging at CHR. And mobility was a key pillar in CHR Institute of Aging. And I proposed to Ann Matthews, why mobility alone? Why not mobility and cognition? And we created this workshop in London, Ontario, and you can see several members, usual suspects, all of them today here in this talk, were key part of this mobility and cognition workshop sponsored by CHR. Importantly, we detect several gaps. The most important gap is we detect that sometimes those research have been in silos. Those people doing clinical or research in mobility problems, they didn't explore cognition, and vice versa. Those clinicians and researchers doing a lot of research in cognition didn't explore mobility. And we do know that both interact and concur, particularly in aging and in older people. So how can I study this gait and brain connection? Well, one way we experiment that was with the dual task paradigm, doing two things at the same time, walking and talking, for example. And I'm going to show some videos. This is a video we took in a patient that was part of our gait and brain study. That was in 2007. And you can, for those that are home in Parkwood, this is a corridor near our division of genetic medicine where we place this mat in order to measure gait. That mat has sensors, so I can obtain quantitative, spatial, and temporal parameters of the walking. And this gentleman asked just to walk, and his walking was quite normal. He was 72, having mild cognitive impairment, but having a normal walking, and mainly no any problems when he tried to walk. And in fact, the gait speed, the velocity he was walking was quite fast, 1.5 meters per second almost. And the asymmetry between the footsteps, as you can see in the in the pic, are minimum, less than 3% of the confidence variation. Later on, I asked this gentleman to walk while doing a mental challenge, calculation, subtractions by 7 from 100. 100 minus 7, 93, 93 minus 7, 86, and so on. As you can see, he started working normally, but later on he hesitated. The arm swing is not the same. He has some tripping and long steps. And the variability you can see on the naked eye was important in this video. In fact, the variability increased. When we measured those, we found the gait velocity reduced by almost a meter per second. That was like a 30% reduction, but the variability, the asymmetry increased to 13%. So that difference between the normal walking and the dual task walking, we call the dual task cost. How much cost to your gait to have that mental or cognitive challenge? And that cost in this gender was 30%. So normally, every one of us, when we walk and talk, or we walk and get distracted, we try to slow down. And that's a normal reaction. Although that should be below 20%, it seems when it's more than 30%, it's a powerful predictor of falls, cognitive decline, mortality, and even dementia. And our labs contribute to generate all this knowledge in the last 15 years, among others around the world. This is a busy slide, but just to show us that the Gain of Brain Health program wants to develop understanding this interaction between mobility, cognition, and mood, wants to apply this understanding, how we can assess that and which intervention we can do, but also want to do knowledge translation. Just to show you some pics of our research, with Susan Moore, at that moment my fellow, now professor at the Faculty of Health Sciences, we were one of the first to determine which is the number about cognitive impairment may predict falls. What is the probability and the relative risk? Later on, we describe the motor signature, which is the motor signature of cognitive decline, which are the gait problems and the balance problems. And also we relate with this frailty. Interestingly, we were able to describe a clear phenotype of those at higher risk to have this decline in the future. And importantly, we look for some correlate with brain imaging. Later on, we look for association with micronutrients, and like a vitamin D deficiency was an important parameter there. And we explore how fear of falling may affect all those relationships. When we went through interventions, we were very interested to see if there is any medication can improve processing speed or executive function. And we found that donepezil in a set of patients may improve gait speed, dual task gait, and reduce falls. The same we did with brain stimulation with Dr. Amer Burman in our collaborations with the mental health. And the same we found in our studies that have done in GRU, led by Dr. Susan Moore. Very proud of the Synergic trial, which is a national trial. We'll provide some details, but just to show you how we try to apply all this in the knowledge. We did some Canadian recommendations on motor markers of dementia, and that's been widely accepted across the country. But also, we're able to demonstrate how dual task gait is independent predictor of dementia in older adults with MCI. We create a national consensus about how to assess cognition and mobility together, and which is a core set of measures, a very small core set and an expanded core set of measurements, how to evaluate that. And we describe how gait variability can be a marker of decline and neurodegeneration across several clinical groups. And with Jill Livingstone, who led the Lancet report about dementia, we're able to establish the pros and cons and how we can prevent dementia with physical exercises and other lifestyle interventions. And now we're leading the global false guideline to prevent dementia. So London, Ontario is in the spot, leading this international endeavor with 48 countries and more than 300 scientists across the planet. But let's focus a little bit on interventions that we're very excited to tell you. The Synergic trial, the Synergic 1, was run since 2013 until last year, and was a national endeavor in where we tried to prevent dementia by combining physical exercise and cognitive training. Here are part of our members, and we were very, very proud to show that that intervention worked to improve cognitive outcomes. And that was in 200 people with MCI, and we found that cognitive training with physical exercises were better than cognitive training of physical exercise alone to improve cognitive performance evaluated with the ADAS-Cog, which is a global test of cognitive performance. Now, I'm very delighted to let you know that the Synergic 2 trial, which is a national trial involving 600 people across Canada, has been receiving funding a few days ago. We got the news for the Western Brain Institute, besides the funding of CCNA. So stay tuned for the result of this national trial. But just to finish, I want to let you know that this national trial has a unique feature that is going to be delivered remotely. This trial, which is part of the Worldwide Fingers Consortium that is led by Mia Kipibelto, will deliver personalized physical exercises, cognitive training, diet, cardiovascular risk factor control, and sleep treatment to people at risk of dementia, 600 persons with MCI and risk factors, and it's going to deliver at home using this digital platform you can see here. It's going to be with effective coaching, and we're creating here in London the Center of Remote Interventions to Prevent Mobility Decline and Dementia. And you can see here, we are going to personalize the menu for each participant, and the participant will see how the progress in a forest plot in each domain we're targeting. And this is going to be with face-to-face, remotely via Zoom using this digital platform with a coach, while in the other 2 weeks, the person or the participant will create or follow all these interventions alone. Just to finish, if you want to learn more, our book is already in Parkwood Library and Western Library, and my email is there for any questions. So thank you very much for your attention. And Jeff, the screen is off.
Yeah, that's great, Manuel. Thank you for sharing your research program. It's really awesome work. And congrats on that large grant. I think that remote intervention is going to be a real big step in looking at the linkage between cognitive function and motor function. That's fantastic. Our last speaker of the night or of the afternoon is Stephanie Cornell. Steph is a physical therapist in our rehabilitation program. She's been working at Parkwood for over 10 years. And recently she moved into a role with the Gray Center. She is now the clinical development, what's your role called? It's the clinical development lead for the Gray Center. And Steph is going to speak about training and coaching our clinical staff. So Steph, take it away.
Sure, thanks, Jeff. So prior to my role as the clinical development and implementation lead with the Gray Center, I was a physiotherapist on the spinal cord injury team at Parkwood. And the spinal cord team is one of many, many specialized programs we have at our center, which makes us super unique and special. And before I talk about how we're integrating technology into rehab, I'm going to take a step back and completely oversimplify what we do in clinical practice. So a patient will come in and they'll undergo a lot of assessment with their team. And then from that assessment, we'll determine which types of therapies would be best for them. So a patient will undergo therapy and treatment, and then we hope that that leads to the best mobility outcomes possible. Depending on how much someone's progressing, we might change the therapy up, we'll reassess outcomes. And so there's a relationship between these two things that we sort of decide how we're changing therapy as we go along. There's many factors that impact what we're deciding, what we're using to decide what therapy we use. So we try to incorporate best available evidence as well as patient preference. So this is huge. What is somebody's goals? What is motivating them? What is it that they want to do in therapy and focus on? And then that's also paired with clinician experience. So after we've been working with in a certain area for a long period of time, we start to see clinical patterns, and that impacts what we decide to use for therapy because we start to know over a period of time what we think is working best. So now enter technology, and we're extremely lucky at our site because we have the most advanced technology available to us in clinical practice than any other site in Canada. So this though adds another dimension, and it affects all of those factors that we use to consider therapy. So as a clinician, I'm now wondering, is a piece of technology even right for one of my patients? Should I be using it at all, or which piece of equipment is best? Should I be using a combination? How do I progress somebody from one to the other? And you guys heard from Paul earlier, and Paul went through our spinal cord injury program. And recently we were having a conversation with some health science students, and Paul did a great job explaining to them sort of what he was doing in therapy. And so I hope I do a justification, Paul, but Paul was going through and explaining to them that when he first was injured and at Parkwood, he started on the Locomat. So that's this piece of equipment on the right. And so that was able to get him upright and moving in a walking pattern over a treadmill when he wasn't able to do that himself. As he progressed, we started using functional electrical stimulation. So that's where we have electrode pads over muscles, and the small bit of electrical stimulation powered your muscle to move through a motor pattern for you. And this really helped Paul understand that pattern and to recreate that himself. And then as he progressed, we moved to the body weight support treadmill. And so that's a little bit more hands-off. It lets somebody be more independent in their stepping and helps them translate what they've learned to then overground stepping. So how do we make sure that our patients like Paul come through the program and they get the right types of therapy for them at the right time? Because we know that you can't just drop a piece of equipment off in a gym and expect it to be used correctly, or that the uptake is going to happen. So we have to be fairly intentional about how we do this. Let's walk through an example. So I spoke briefly about the Locomat. It's a piece of equipment that we do use often with our neurological patients, and it helps somebody move their body over a treadmill and simulate a walking pattern. So we got our Locomat in 2014 through the foundation, and at that time, the manufacturer came up and trained 6 of our staff. Today, only 2 of those 6 work with the Locomat on a daily basis, which seems like a fairly grim statistic, but I would say that's probably pretty consistent with a lot of the technology we have in terms of just when you consider staff attrition, people move jobs. But what does that mean for a patient in 2021? We got the Locomat in 2014. We have people coming through the program now in 2021. And what about for people like Paul coming through the program 5 years from now in 2025? How do we know that the use of the equipment is sustainable? So we've had to develop our own internal training and coaching model. There's lots of different components to this model, and we've applied implementation science, and together with our research partners, our patient partners, and frontline clinicians, we've developed a model that we think is working fairly well on the ground. So we'll only speak to 3 of the components very briefly. But the first one is selection. So not everyone is going to be trained on every piece of equipment. It's not realistic to think that they're going to use it with their patient populations. Some pieces of equipment aren't appropriate for everybody. So the selection of who's getting trained is important because we want to consider resources. Training is an easier component for us to wrap our head around. This is what we typically think of as that checklist of skills that you need to be competent. But a lot of models start and stop with training, and training alone is not adequate enough to consider uptake and to make something sustainable over the long term. You need to pair that with a robust coaching component. So coaching is that mentorship, the real-time decision-making, the stuff that, so to speak, isn't in the manual. So we want to make sure that after somebody does training, they have ongoing coaching and mentorship from their peers. And so that's something that we really think we need to focus on as well. So what's the impact of our training and coaching model? Well, we can look at the numbers. So we're able to track the amount of use on all of our different pieces of equipment because of the scheduling system we use. So there was over 50 patient sessions in September alone on the Lokomat. Over the years, we have trained well over 20 staff to be independent and completely certified to use this piece of equipment. And we've also trained countless students and volunteers. And they are a part of making sure that we're very efficient at using this equipment, so that many of the pieces of equipment in the practices take multiple sets of hands. So the students really help support this in practice. And that's a different training stream as well that we consider. So again, I'm going to kind of oversimplify. There's always going to be new practices that we're trying to implement, new pieces of equipment. Rehab is moving quickly and there's lots of new technology. So if we look at a group of frontline clinicians on the ground, some of them will be trained in a new practice or piece of equipment, and some of them won't be because of the selection process. And as people start to use the equipment more with their patients, some of them will emerge as champions of their practice and on these pieces of equipment. Our job is to identify them, empower them, and support them, because these people become the coaches that completely drive the practice on the ground. So as we move forward with our training and coaching model, we want to continue to implement it and evaluate what we're doing. Our overall goal with using technology is to increase therapy intensity when it's appropriate to use technology. But we want to make sure that we're evaluating our practices to make sure they are making an impact. So this is a functional electrical stimulation bike over here on the right. And as we're tracking the use of that, we can determine whether or not some of our initiatives are working. So for example, we saw an uptick in August, and in July, we provided some training for our staff. So we can use things like this to see whether or not some of the different things we're doing are working. Then I think we really want to understand the relationship between equipment use and mobility outcomes. We hope that it's improving the outcomes of our patients, that they're able to move better after using it, but we really need to do a better job in understanding this relationship. And we want to continue to spread and scale. So as we get new equipment or are applying new practices, we want to be able to apply our model to that. And we're uniquely positioned at our site because of the amount of expertise we have and the amount of equipment we have, that we have provided consultation services across the country on this model. We have a real potential to become a teaching and education hub because of this level of expertise. And Jeff told me that the bottom line of this slide was that we're going to take over the world. So we'll see how that goes. But thank you to all the team that was involved in our training and coaching model. So it really is a collaboration across our students, our frontline clinicians, and our research team. So thank you.
That's great stuff. Thanks a lot. And just before we wrap up, it's important to note that over the next couple of years, the Gray Center is planning on making significant investments to improve or enhance the technology and equipment capabilities we already have. So it's really can't be overstated how important this training and coaching model will actually be as we move forward. So just before we wrap up, I'd like to quickly share my last screen. And that is to, again, highlight our upcoming presentation by, again, Swati Mehta, which will be happening in January of next year on her virtual interventions. We would really look forward to that. And on the right are all the contact information of those that spoke today. If you have any questions, please feel free to reach out to any of us, and we would be happy to discuss your questions further. We really appreciate all your time, and we're really excited to move mobility and activity forward in the London community. Thanks a lot, everybody.